federal block grants and state opioid response grants, and opportunities for health centers for collaboration with traditional substance use disorder treatment providers. For today's webinar, we have invited 3 states to present on their innovative and promising practices, such as medication-assisted treatment, integration of addiction treatment and primary care, paying for housing with individuals with opioid substance use disorders, and we will finish with a Medicaid managed care organization who will talk about a managed care response to the opioid crisis. Just for your information, we will have the slide deck and the recording available by early next week, so we will send you all the slide deck and a link to that recording. I'm having trouble advancing the slides here. Let's see. My screen is frozen. Jen, can you advance the slides for me?
Sure thing. We're on the second slide, addressing the opioid crisis series.
Yeah, we should be coming up to the Rhode Island slide.
All right, we have Rhode Island up next.
Great. So I'm going to turn this over to Ryan Erickson from Rhode Island. Ryan's the policy advisor to the governor of Rhode Island. So Ryan, take it away, please.
Sure. And sorry in advance, I don't know if I'm doing something wrong here, but there we go. Okay. I have the right slide up. Hello, everybody. As Sue indicated, I am a policy advisor to Governor Raimondo here in Rhode Island. As a policy advisor, I work principally on all things related to our state's response to the opioid crisis. So what I'm going to do with my presentation today is try and give a really brief overview of the kind of big picture of what we're doing, and then spend a little bit more time on some issues that we've managed here in Rhode Island that might be of interest to health centers, to primary care networks, and others in particular. So if we could go to the next slide, please.
I think Jen's going to have to advance them because for some reason my ability to do that has frozen.
Oh, excellent. There we go. All right.
There we go. Whoops. Now we...
Gotta love technology.
Okay. Yeah.
So just briefly, our historical context here. In 2015, Governor Raimondo came into office and very shortly thereafter convened a task force, the Governor's Overdose Prevention and Intervention Task Force, to take on one goal, and that was save lives. At that point, the number of overdose deaths in Rhode Island was climbing pretty drastically every year. We were, at that point, we had one of the highest per capita rates of fatal accidental drug overdoses in the country, and one of the very highest. It was pretty clear, broadly recognized by a number of sort of the traditional players in our substance use treatment space, as well as a big community of other people in the state, that this was a public health emergency unlike anything in our state's recent history, so that we needed to act quickly. So the task force consists of a pretty, as I indicated, a pretty broad array of people from across sort of every imaginable stakeholder group that has some part of our response to the opioid crisis, including government leadership, the state's major healthcare providers, including our major hospital systems and networks, our opioid treatment providers, of course, health centers, insurers, and plenty of others. The task force is co-chaired by the directors of our Department of Health and our Department of Behavioral Health Care, Developmental Disabilities and Hospitals, which is our behavioral health authority in Rhode Island, and also the senior advisor to the governor, Tom Coderre. The task force is also assisted by expert advisors who drive a lot of the content of our work, the experts in very varied fields, but including addiction medicine, recovery programming, pharmacy. We have also sociological sociological expert on people who use drugs, and some others as well. The core work of the task force is sort of it gets funneled through these 8 groups. We have dedicated to prevention, treatment, rescue, and recovery, which are I think I might touch on briefly in the next slides, and then these 4 other cross-cutting issues that we found important to establish work groups around. One is law enforcement and first responders, families, substance-exposed newborns. It's responsible for that work group is responsible for setting a lot of our policy around neonatal abstinence syndrome and the state's response there, as well as harm reduction strategies. If we could go to the next slide, please. So we sort of outlined our major actions through the end of 2018 on an original. We had an original 3-year plan after the governor convened the task force in 2015 through the end of last year, where we outlined 4 general areas where we knew we wanted to structure our work. One is that the 4 areas are prevention, rescue, treatment, and recovery. I'm just going to highlight some of our successes, or some of our, I guess I don't think all of these are successes, some of our actions in each of these areas. One, from the prevention front, we recognized early on that we wanted to make a pretty significant dent in the number of opioid prescriptions issued. And while Rhode Island doesn't have a strict limit on, or an outright prohibition on the number of the number of MME equivalent, the number of MMEs that can be distributed to a person within a particular time frame, we do have requirements that after 7 days, these are pretty standard requirements across many states now. After 7 days, people follow up with their doctor and check in before any subsequent prescription. We also have tailored alerts for co-prescribing of benzodiazepines and opioids, or if people see more than one doctor or visit more than one pharmacy to fill an opioid prescription, a number of other things using our PDMP, our prescription drug monitoring database. For our rescue, so we've made some progress there, decreasing the number of overall opioid prescriptions, but we still have we believe we still have a good distance to go. Rescue, we've set yearly goals of distribution of naloxone kits in publicly available settings generally. We set a goal of 10,000 for 2018, which I'm happy to say we blew out of the water. We're a small state, so that's a pretty significant number for us. But we distributed over 16,000 kits, and I don't think that count is even final. We'll probably end up somewhere closer to 20,000 when the final number comes in. If we could go to the next slide, please. For treatment, most of our treatment strategies have focused on the proliferation in various ways of medication-assisted treatment. We have had some success there. We've seen, although not as quick as we'd like and not meeting our projected goals, we have seen some steady increases in the number of people receiving a buprenorphine prescription per year. We have other metrics not shown here about their sustained engagement with that treatment that we're also refining, but that indicate generally people are staying in treatment for 6 months to 12 months to different treatment windows. And then also we had still have a pretty active network of opioid treatment providers who have methadone, make methadone available to clients, where we've also seen some pretty consistent increases since the task force took off. For recovery, we have a pretty robust suite of recovery services in state, including a number of different ways we've deployed peer recovery specialists. I'm going to talk a little bit more about that shortly. The number of peer recovery specialists that we've trained and then also made available, we've tried to really make sure we drive increases in that. There have been some challenges associated with that just because we'd like it to be a more well-remunerated field. We'd also like there to be more organizations willing to host peers. We're continuing to work on that, but we've also been able to meet some goals in increasing the number of peer recovery specialists we have available. If we can go to the next slide, please. So going forward, we're sort of taking the so just to note, we're projecting this year the count for accidental overdose deaths on the graph here is not final. We're projecting to land somewhere around 300, which will represent 2 years of decreases in accidental overdose deaths, which I think is promising in some ways. I mean, I think we broadly feel across the state the only acceptable number of overdoses, accidental, fatal, non-fatal, or otherwise is 0, and we're going to do everything we can to get there. We did, originally set a very ambitious goal of trying to reduce overdoses by 1/3 from our 2015 target. It's the 160 number there. We did not meet that. I mean, certainly it was before the advent of fentanyl and a number of the other challenges that have really defined this crisis. But we are seeing some momentum, and we're pleased but cautious. And going forward, we're going to focus a bit more on primary prevention strategies, communicating directly with people about the risks of opioid use, and that hasn't been as much of a focus of our primary efforts, of our first suite of efforts here for these first 3 years. We're going to target our naloxone distribution a little bit more specifically to our hardest to reach populations, where we've had some trouble getting naloxone and other rescue resources to connect. We're moving as much as we can toward a treatment on demand model generally, so that particularly medication-assisted treatment, but any form of treatment any form of clinically appropriate treatment is available to anybody who it might help at any moment of the day to pull people through a window of willingness if they're willing to engage with the treatment program. We're looking to create meaningful career opportunities for people who are recovering from addiction as a way to sustain their recovery. One of the best ways to sustain recovery is through employment. There have been a few studies that show this, and there are a few other actions we have. I'm happy to make our new strategic plan, but actions we're thinking about in the coming years, the next 3 years. I'm happy to make that available to anybody who's interested in learning more. If we could go to the next slide, please. So for our deeper dive here, I'm going to focus a little bit on 2 areas. One, the use of peer recovery specialists here in Rhode Island, which we think can adapt well in primary care and health center contexts, and also expanding access to medication-assisted treatment through primary care settings. If we can go to the next slide, please. All right, so peer recovery specialists in our crisis response. So generally speaking, peer recovery, well, so not generally speaking, as an absolute, licensed peer recovery specialists in Rhode Island, they are licensed, have to go through a training certified by BHDDH, our state behavioral health authority. There are 2 organizations that are sort of the leading organizations that train most of our peers in state, though there are a couple of others who are coming online. I think there's it just sort of speaks to the broad recognition that this is a growing area of need. And also too, I guess I really should back up too and just sort of generally speak for a moment about peers. Peer recovery specialists, which is the term that we use here in Rhode Island, but it could be peer or peer mentors, they're effectively people who have had an experience with substance use disorder themselves, who are now acting as a sort of a go-to trusted person for somebody struggling with active addiction, as a way to sort of help show them the way into recovery. That's the general model, and I know that the terminology is a little bit different across places, but yes, here we call them peer recovery specialists. We were the first state to make peer recovery specialists available to respond to overdoses at the emergency department 24/7. So right now in Rhode Island, anybody who's admitted to an emergency department for overdose, it can get a referral to a peer recovery specialist, and usually a peer can be at the emergency room to meet with that person within a half hour. Sometimes a little bit more, but usually a bit less. Depending on and at different hospitals throughout the state, we can usually make people available pretty quickly, and we have peers in different parts of the state. Through our Anchor More program, Anchor More I think stands for Mobile Outreach Recovery Engagement, is a direct to the streets program where peers go out and speak directly with people in active addiction, either who don't have a stable, who are unstably housed, or otherwise there's some indication of their substance use happening outside on the street, and they try and engage people into treatment and into recovery program through direct outreach. Peers can also meet clients through Providence Safe Stations. So Providence, of course, is our largest city and has a network of fire stations that are also, of course, as fire stations. They're open 24/7. Anybody in Rhode Island can, or anybody from anywhere can walk into a fire station in Providence, speak with one of the firefighters on duty, and they can get an automatic referral to a peer recovery coach who will come to meet that person any time, day or night. Peers, we also in Rhode Island, we also just very recently opened a behavioral health crisis triage center, BH-Link, which is also a 24/7 resource. Anybody can, either through EMS or through, oops, my screen just went dead, either through EMS or through walk-in referral or through a peer, somebody can be brought to BH-Link, where peers are also peer services, peer recovery services are also available. If we can go to the next slide, please. And we just recently got some, so that all speaks to I think that generally outlines most of our actions with peers, which are pretty extensive in different pieces of our overdose response. Just recently, we've gotten some really interesting early data on the effectiveness of peer programs. One study was undertaken by our internal analytics team at our Behavioral Health Care Authority, showed that interaction with a peer through Anchor ED, the program that goes to emergency rooms, sends peers to emergency rooms, were 42% less likely to experience an overdose subsequently. People who interacted with a peer through Anchor ED were also 20% more likely to get connected with a state-licensed treatment provider. And then I guess we can go on. Sorry, next slide. We also can be so just really quickly. I know I'm probably running a bit long here. Peers can we feel that there are a number of ways peers can be plugged into primary care settings that we've seen here in state. They're pretty easy to plug into health center infrastructure if there is already a behavioral health infrastructure in that office or in that center. They can provide valuable treatment-focused and recovery-oriented support to people in primary care settings or health centers. They also, could be. We're trying to also. I don't have this here, but we're also trying to set up a model where they're a little bit more focused on. We have some peers who are a little more focused on medication-assisted treatment as well. We feel that we can engage people and create a medication-assisted treatment focused peer model that I think we'd also like to see placed in primary care settings or in health centers. You could also consider partnering with an organization that offers peer services to ensure expertise and capacity. If peer services are not within the scope of a health center's general service array or within the size or imprint they have. One example is that we've also bundled peer services through our IHH integrated health homes programming, opioid treatment health homes programming, which I can go into separately if anybody wants to follow up on that later. But that pairs one of our community mental health centers here in the state with one of our state's largest FQHCs. Rhode Island's also made peer recovery services available through billing through Medicaid, through our just renewed Medicaid global waiver. If we go to the next slide, please.
Hey, Ryan, can you maybe wrap it up in a minute or so?
Sure. And I just wanted to touch quickly on medication-assisted treatment in primary care. So some of this is, I think the most important point here to emphasize is that we recognized we needed to scale up a pretty significant amount of available resources for medication-assisted treatment around the state, particularly on buprenorphine, because as I indicated a little bit earlier, we did have a relatively robust network of opioid treatment providers, but we created a system of centers of excellence. And the way we sort of see our centers of excellence really work, where they really excel, they're kind of like one-stop shops for buprenorphine care, particularly buprenorphine, but I think some could be, the model would be adaptable to methadone too, is that we set up an infrastructure for primary care offices and health centers to do basic maintenance of medication-assisted treatment with data-waivered physicians, but can refer any complexity or any other services needed associated with medication-assisted treatment to one of these centers of excellence, and cycle patients back through and in and out as necessary. So I think we can skip this slide. So this is also something I can make, but just very, very quickly, we have some models where we've seen it works that primary care offices, they want to take on the entire responsibility. They might dedicate one day to medication-assisted treatment management visits, and that's been really successful for some of our primary care providers. But the other model we've seen is that is the one I just mentioned, where a primary care office or a health center can work with the center of excellence to coordinate someone's medication-assisted treatment care. And we're just looking to propagate this model more. And that's it. Sorry I went over.
No problem. Thank you, Ryan. We did have a question for you, but I think, Katie, if it's okay with you, we'll hold that till later to make sure we get through all the presentations. So you could see that question in the chat,
yes,
Ryan.
Sure. If I can answer it in the chat, I'll do that.
Okay, thank you. So we're going to turn it over now to Mark Stringer, who's the director of the Missouri Department of Mental Health. And Mark, you can take it away. Thank you.
Okay, thank you. And I'm joined here by Rosie Anderson-Harper and Nora Bach from our Division of Behavioral Health. So let's go ahead and go to the first slide, please. Missouri's been hit by the opioid epidemic really hard, like most states, and with the introduction of fentanyl, it's become also a poisoning epidemic. In 2016, we had 908 deaths, which was a 35% increase from 2015. Next slide, please. But then the following year, in 2017, we still saw an increase, which is still unacceptable, but it was only 4.7%. So we were making progress, and that progress we believe was attributable in many ways to the federal grants that we received to fight the opioid epidemic, the state opioid response grant and the state targeted response grant. Next slide, please. So we had been, before the epidemic hit, we had been on a 10-year journey to enhance our services to include medication-assisted treatment. It was kind of a rocky start, but we are fortunate in Missouri to have a very cooperative, good provider system. It took a lot of training, a lot of coaxing, just a lot of various interventions. But finally, in Missouri, in all of our treatment programs now, medication-assisted treatment is available in the form, and then for opiates, in the form of injectable naltrexone or Suboxone. Next slide, please. Oh, I'm sorry, stay here. So what we've been doing is promoting individualized care, reducing residential stays, again, encouraging the use of medications, expanding our service menu to make treatment just better, and then, again, providing a lot of training and technical assistance. Next slide, please.
We're very fortunate in the state of Missouri to have strong relationships with our partners. So we work well with our Mo Health Net division, which is our Medicaid entity, and with our partners, the treatment providers and recovery providers. So we have a foundation of integrated services in Missouri that we've been working on the last few years, and then this opioid services, we were able to build upon that foundation. So I mentioned three programs that we have going on for integrated services. We have disease management, and that's been for the high utilizers of Medicaid services. So Medicaid tells us who the high utilizers are. Our service providers, our treatment providers, outreach to them, connect them to the behavioral health services so that we can better monitor their physical and behavioral health. And this program has really improved the health outcomes for individuals being served, and has actually saved us money for the state. We also have a community mental health center healthcare homes. That's where we've integrated the physical health care into the behavioral health program and assist those with chronic conditions. And that also has shown great health improvements, outcomes, and decreased use of emergency room visits and hospital stays. We also have added emergency room enhancement programs at in many regions of the state. That, again, is designed to reduce unnecessary emergency room utilization by connecting the individuals that come into the emergency room with a behavioral health condition to their local provider. That has been shown to reduce the emergency department and hospital day stays. It has also decreased homelessness. It's also been a good contact with law enforcement, and it's increased employment among those who are engaged. So again, these are what we're building. These are the foundations that we're building the opioid program on. The specific opioid initiatives in Missouri, you can go to the next slide. We have prevention, treatment, and recovery. In the prevention realm, we've been doing a lot of training for physicians on pain management. We have an ECHO or a telehealth meetings that we have that the physicians can talk about specific cases. We've done a lot of overdose education and naloxone distribution. And we also have a listserv with over 700 individuals on it, last count. And that includes anybody who's working in the opioid world. So it's courts, providers, physicians, the Department of Mental Health, behavioral health system. So there's a lot of good dialogue that goes on and information sharing. In terms of treatment, again, we've been doing a lot of provider training. We've done a lot of healthcare integration. We've increased access to the evidence-based practices, medical treatments, and include telehealth in that. And then in the recovery realm, we have done a lot of building with these dollars from the state opioid response grant. So we've been able to add peer support, recovery housing, and recovery community centers where we didn't have some of that before. So again, similar to Rhode Island, we have been building a workforce of certified peer specialists to help individuals meet their recovery goals. So currently, we have over 700 active certified peer specialists in Missouri in the behavioral health system. So that's not just the opioid treatment, but in our whole behavioral system, over 700. In terms of recovery housing, we have 62 recovery houses. This opioid money, we were allowed to, we had the funds then to have an affiliate for the National Alliance for Recovery Residences. And so we have over 693 approved beds, and we didn't have that before. We didn't have the quality indicator with the NAR accreditation, and we weren't funding near that many. So that's been a big improvement that we've been able to use these dollars for. And then in terms of recovery community centers, we now have 4 funded recovery community centers to provide opioid use disorder recovery services. They are independent nonprofit organizations that mobilize their resources to increase the prevalence and quality of long-term recovery. They provide recovery coaching, recovery meetings, life skills groups, and other services. And they have served over 14,000 individuals this year. Over 8,000 of those had opiate use disorders.
That was Rosie, and now we'll hear from Nora.
You can advance the slide. So one of the major projects that we've been working on in response to the opioid crisis has been a revamp of our treatment model as it relates to how we address opioid use disorder. And what has come about through some work with our partners at our research partners and our treatment providers is called the Medication First model. And Medication First, the name is borrowed from the Housing First approach to homelessness, in that you first address their prior priority needs, which if you're homeless is housing. And in the opioid use disorder, what we've realized is that until you stabilize someone's physical symptoms associated with withdrawal, you're not going to get very far with the other interventions that you tend to use to promote their recovery. So in terms of medication first, as you can see on the screen, there are 4 tenets of that model. And the first one is that people with opioid use disorder receive medical treatment ASAP, and that's prior to putting them through very long assessments or treatment planning sessions, or saying that you have to see a counselor 5 times before you can see the doc, all those sorts of barriers. The second tenet is that maintenance medications are delivered without arbitrary tapering or time limits. That's been a very interesting and liberating component, frankly. We don't have any limits that says you can only be on buprenorphine for 6 months. We don't have limits that say after 6 months you have to begin a taper. You are on it as long as you need it, as you would be for medication for any other chronic medical illness. The third tenet is that individualized psychosocial services, whether that be counseling or peer support or case management, these are offered to these individuals, but they are not required as a condition of medication-assisted treatment. And that has come as kind of a shock to a lot of folks in our system. But the point is, again, we are treating first and foremost the medical aspects of their disease, and then when they are stabilized and ready to explore the other pieces of their needs in recovery, that's when they do it, and they get a large choice in what that looks like. And finally, with medication first, it's that medication should not be discontinued unless they are clearly worsening the patient's condition. So you are not held to some sort of level of success in order to continue on your medications, because first and foremost, these medications, by and large, are keeping you alive. Next slide. With that said, we encountered some barriers. Again, this is sort of a new way of thinking for many providers. And as any good bureaucratic system should, we had many barriers that we had already put in place that we had to address. For example, our billing requirements and intake procedures did not lend themselves well to the model I just described. As many of you are familiar with, the Medicaid state agencies have varying prior authorization rules or other clinical edits that limit or put in some sort of restrictions on the use of buprenorphine or other addiction medications. We were seeing an overuse of group services, non-medical detox, and residential support for the use for opioid use disorder, which is largely contraindicated. We were not paying our providers well enough to really support the model that I just described to you. We had a high administrative burden with low rates of reimbursement for medical services, and Missouri generally has a lower number of buprenorphine prescribers. Next slide. So the solutions that we did to look at those barriers is to streamline our requirements and extend time to complete the assessment. We actually worked well with Medicaid to relax many of the buprenorphine limitations. We restricted the use of services on the menu that were not strongly evidence-based. We were able to increase the payments that we made for medical services, and we, as part of our opioid federal grants, have been able to offer free opioid waiver training to physicians. Next slide. And real quickly, this encompassed more than I have time to describe an extensive training effort statewide that was multimodal and multidisciplinary that covered a range of the role of brain chemistry, profession-specific breakouts we had to address how each professional can address successfully the recovery components, and we had to get over attitudinal barriers as well, but these have all been very successful. I'm going to turn back to Rosie for just a minute.
Okay, we also have a behavioral health network with one of our organizations in the St. Louis area. They have an opioid overdose project. It's called EPIC, stands for Engaging Patients in Care Coordination. I'm very excited about this because what it is a recovery support specialist, similar to what Rhode Island was saying. They will come to the ER when someone has overdosed on an opioid. They will try to engage that individual in engaging in behavioral health services. So we have had instances where someone will overdose, they'll get the naloxone, they'll get into the emergency room, they'll get connected with a peer recovery coach, they'll start their medication-assisted treatment that day, they will get into treatment with a treatment provider the same day or the next day, and then they'll also have a place to spend the night because they'll get into that recovery housing that night. To me, that's optimal. That's getting that person right then, right when they're in pain, and probably willing to engage into some services. So we've had great success with that. We provided more than 2,200 individuals that EPIC service since May of 2017. And because it has been so successful in St. Louis, we now have some state funds where we're launching it in 3 other sites in the state of Missouri. Next slide.
Hope you haven't been distracted by the tag team approach Missouri's taking here. This is Nora again. Another exciting component I think we've done well at is targeting and supporting the FQHCs in our communities. The opioid crisis cannot be managed sufficiently by the specialty addiction provider system. It just can't. It's an overwhelming demand, and in so many ways, other environments can be used to treat this disorder successfully. So certainly with a medical model such as this, we need doctors and other prescribers. So part of our efforts have been to outreach to the Primary Care Association and to offer training and technical assistance to their primary care centers and hospital systems. Since almost 2 years ago, we've had more than 30 trainings that have been offered in these settings with 875 individuals participating. We've offered 7 webinars that focus on primary care relevant topics, and we have 6 more of those scheduled. And those include things like an embedded counselor model with a primary care, the treatment of Hep C and opioid use disorder. It talks about harm reduction, the use of motivational interviewing, and regulatory issues, to name just a few of the topics on those webinars. And several of our specialty substance use disorder treatment providers are partnering directly with primary care providers to, and they benefit each other. So the psychosocial provider may need a prescriber to do the medical management part of the opioid use disorder, and then the FQHC, if they don't have a strong behavioral health consultant staff or need more of them, they will partner with the substance use disorder treatment center to partner and deliver appropriate services in a comprehensive fashion. So I'm very, very excited about what we've done in terms of outreaching in that regard, because I think that will give us some level of sustainability that we wouldn't otherwise have in terms of addressing this from a community perspective.
Okay, so to wrap up quickly, next slide, please. Yeah, we have major use of telehealth in Missouri. Missouri is a very large state, a lot of rural areas, and so we have really ramped up our telehealth. Next slide, please. And then the last thing, and I think we've already mentioned this, is that we have a very active listserv, which I have found fascinating. Of course, I don't have much of a life, but
anyone can join. Yeah,
and anybody can join it. And there's the I think the information is in there. But if it's not here, you can certainly email me, and I'll get it to you. So that concludes our presentation.
Great, thank you, Mark. Before we move on from you guys, we had a question from Jacques Thornton. So this can go to you and also for our other presenters as you think about your sections of today's presentation. Jacques was asking, what percentage of population, of your populations are older adults, 55 and over? Are there recovery strategies which work best for this population, such as peer support programs? What assessment tools are you using, and can you share those? Have you ever tried community-based asset needs mapping with focus groups, and if so, please share those types of questionnaires. So it's kind of a multi-purpose question there, but I don't know if any of that resonates with you, or that's also just something that any of our other presenters can be thinking about.
It's not a strength of ours. Let's say that. Most of our population are younger adults, and who tend to get in trouble with the law or with at work or whatever. And so that's really been our focus. I don't have an intelligent answer for that
one. Ryan, do you want to respond to that before we move on to Pennsylvania? If not, maybe we'll just move on to Meg Sneed, who's with the Office of the Governor, Secretary of Policy and Planning, who's going to talk about Pennsylvania's response to the opioid epidemic. Go ahead,
my
Meg.
apologies, I couldn't get off mute, but I'm happy to answer that later.
Okay, thanks, Ryan.
Thanks, Sue. Like you said, I'm Meg Sneed. I'm the Secretary of Policy and Planning in the Governor's Office in Pennsylvania. I was previously in the role of Deputy Secretary of Policy and Planning, overseeing the health and human services agencies in the state and taking the lead on the Governor's heroin and opioid agenda. So this is an issue that's near and dear to my heart. If you can advance to the next slide, please. What you see here is really a laundry list of the initiatives that we have implemented over the last 4 years. Governor Wolf won re-election this year, so as we enter into our second term, I'll back up a little bit and talk about how we sort of took an approach to addressing the opioid epidemic when we first came into office, which I think is really important context to where we got to where we are today. We've really, in our first 4 years, I would say the first year was largely spent wrapping our arms around the nature of the epidemic, the size. Pennsylvania has been hit particularly hard in both our rural and urban areas. We've bucketed our strategies into 4 main areas: prevention, rescue, recovery, and treatment. The first year, I would say, was really crisis management, building out our IT structure, trying to understand how prevalent the problem was, where we were looking in terms of which areas of the state were hit the hardest. We were really successful in achieving some bipartisan support around this issue, which in Pennsylvania is not something that comes very naturally to us on a lot of issues. We have a Republican-controlled legislature and a Democratic governor. This is something we've been able to work across the aisle on, and we were successful in passing 5 major pieces of legislation in our first year to address the heroin and opioid epidemic. We were really focused on cracking down on the overprescribing of illicit opioids, knowing that that was a huge factor in how widespread the epidemic had become. In our second year, we focused much more on building out treatment capacity, expanding the use of naloxone and getting it into the hands of first responders, ramping up our prescription drug monitoring program, which previously sat in the Pennsylvania Attorney General's office. We shifted that over to the Department of Health to take a much less punitive look at how doctors were prescribing and a much more clinical approach to that, so that we could work to really change what had become ingrained behavior among providers across the state. In our third year, and that has bled into our fourth and now our 5th year, we've really focused on the continuum of services that can support long-term strategies. So the governor charges us all the time with putting in place strategies that last well beyond our tenure in the building, and that is particularly important when we're talking about heroin and opioids. When we first came into office, what we largely saw as an opioid overprescribing epidemic quickly shifted to a heroin epidemic, moved into a fentanyl epidemic, and now we're beginning to see is really stretching into other substance use disorder more broadly. So seeing a reemergence of methamphetamine, crack cocaine, depending on what area of the state you're in. So needing to put in place strategies that can be flexible and nimble and respond to the changing face of this epidemic. A lot of what we did in achieving support with, you can go to the next slide, I'm sorry. Thank you. A lot of what we did in achieving that bipartisan support was really important, but it was also important for us to look at what executive strategies we could put in place or take in order to continue to address this epidemic. In January of last year, the governor signed a disaster declaration for the heroin and opioid epidemic. It established the Unified Opioid Command Center, which at the time was spearheaded by our Department of Health and our Department of Drug and Alcohol programs, and has grown to a weekly meeting that consists of 16 state agencies sitting around the table talking about strategies to address this epidemic, and it's been incredibly successful in helping to break down barriers and silos to increasing access to treatment, prevention, rescue, and recovery strategies. So because Pennsylvania is one of the hardest hit states, we're in the top 10 of hardest hits. The federal funding that we receive, we're eligible for an additional pot of funding. We received 2 years worth of 21st Century Cures Grant dollars that totaled $26.5 million each year. And through that initial funding, we expanded access to treatment for the uninsured and underinsured through our single county authorities, which are the local entry point into the drug and alcohol treatment system in Pennsylvania. We established a PACMAT program, which is a Pennsylvania Coordinated Medication Assisted Treatment Program, and that's replicating Vermont's very successful hub and spoke model. We launched public awareness campaigns. We increased funding for drug court treatment programs with the goal of really focusing on diverting those individuals away from the criminal justice system and into the treatment that they need in order to stabilize. We further funded enhancements to our prescription drug monitoring program, including integration with electronic health records. We held 4 regional warm handoff training summits, and I'll get to something that has been born out of that effort. Those have been really successful in educating healthcare providers across the state in warm handoff protocols and how to quickly get somebody from an emergency room into treatment, utilizing what a lot of other folks have talked about, the peer recovery specialist as a linkage to that treatment, and making that very successful. We built out school-based student assistance programs to look at curriculum and how we were educating students and to some extent their families at much earlier ages on the dangers of opioids and heroin. And we focused on workforce enhancement for special populations. Pennsylvania is a very diverse state. We looked at really building out workforce initiatives that created more cultural competency to address special populations like a large Bhutanese population that lives in the middle of Pennsylvania to really try and understand how we could get at the root of some of the cultural distinctions that are unique to these populations and how we can adjust our education strategies to better meet their needs. Go to the next slide. So this past year, Pennsylvania was eligible, like every other state, for the State Opioid Response Grant, the SOR grant. We got $55.9 million, again, because we're one of the states that was hardest hit by the epidemic. We anticipate this coming year that will rise to $75 million that we receive and the funding streams overlap a little bit because the CURES Act funding runs on a fiscal year model and the SOR funding we received in October. So we have gotten a huge amount of federal dollars to assist with addressing the epidemic in Pennsylvania, and it's been incredibly helpful. So through the SOR funding, this is where we were really able to focus on building out more holistic strategies to address the epidemic. We're again focused on continuing funding for the single county, enhanced funding for the single county authorities to ensure that they're able to treat uninsured and underinsured populations, continued funding to replicate and expand the PACMAT program, increased funding for warm handoff trainings, and continuing our public awareness campaign. Go to the next slide. But in terms of new projects, we really bucketed the SOR funding into 3 areas. We took a look at the data that was coming out of our centers of excellence, which are programs that serve largely a Medicaid population, wraparound services for individuals with opioid use disorder. We looked at what are the social determinants of health that are most prevalent, that people are reporting the biggest barriers to achieving recovery, and at the top of that list was housing. So this year's SOR grant funding, and it'll speak to it a little bit on the next slide, includes $15 million set aside for an opioid housing initiative. There's a major criminal justice component, including expanding access to all 3 forms of MAT for the more than 40,000 individuals that are incarcerated in our state correctional institution and the thousands more that are in county jails across the state. We've been successful on expanding access to Vivitrol behind the walls and linking that to our Medicaid program to enable access to that. And much more likely for people to be successful on Vivitrol if they receive 1 shot behind the walls. So this year we're looking to expand that to 3 shots behind the walls before somebody is discharged, and then increasing access to methadone and buprenorphine. They'll also be hiring in our Department of Corrections an in-house medicine specialist, addiction medicine specialist, that can focus on that unique population and better meeting their needs. And then aligning with the governor's broader budget-related goals, really focused on workforce initiatives, including establishing a Pennsylvania opioid use disorder loan repayment program that both physicians and other healthcare practitioners are eligible to apply to receive loan forgiveness if they serve in a health professional shortage area and also target a majority population suffering from opioid use disorder. And then a partnership with Pennsylvania businesses to ease employment difficulties for individuals in recovery, and that's really focused on removing regulatory barriers and other punitive policies that tend to be in place for individuals who have either been incarcerated or are in recovery. Great. Sorry, I just coughed. So like I said, the $15 million of the $55.9 million that we received this year in SOR funding is being set aside for an opioid housing initiative that is running through our Department of Human Services, Office of Mental Health and Substance Abuse Services program for the implementation of pilot projects providing evidence-based case management, housing, and housing services to individuals with opioid use disorder. Go to the next slide. These pilot projects are being funded through the end of September 2019 with the possibility of a 1-year extension. That's very likely to occur. It's just somewhat dependent on the federal funding and when that comes down. We recognize the difficulty of being able to scale up meaningful projects only knowing if there's 1 year worth of investment. So we're doing our best to backfill that with state dollars, but right now grantees have been told they should only count on 1 year's worth of funding. The grant establishes partnerships with providers in designated rural and urban counties across Pennsylvania. We targeted the top, I believe, 15 urban, 15 rural counties with a competitive request for proposals. I believe there are 19 awardees. We're still in a competitive procurement process and working out some logistical details with those grantees, but got a huge amount of interest from communities across the state. So hoping to I was actually hoping by today we would know who was being funded, but I'm happy to share that information for anybody who's interested once we release those details. Go to the next slide. So I won't spend too much time on the top of this slide, but through these grants, DHS will implement pilot projects which provide the following to individuals with opioid use disorder: case management, housing, and housing services. We really wanted these dollars to be flexible for local communities to tell us what their needs are. what we've found is that Pennsylvania is a big state. There's a lot of great innovative work happening in various communities across the state, and we didn't want to be so heavy-handed as to assume that what works in Philadelphia County also works in Erie County on the other side of the state. So to the extent the Substance Abuse and Mental Health Services Administration allowed us to, we were really flexible in how we wrote the competitive RFP and how we intend counties and other eligible applicants to be able to spend those dollars. Go to the next slide. So the case management that is funded through this grant must be comprehensive and evidence-based. It must assist individuals with opioid use disorder in remaining engaged in treatment and achieving overall stability and independence. And it must be centered around assisting individuals with opioid use disorder with accessing recovery services, connecting with community resources to meet their immediate basic needs, addressing barriers to self-sufficiency, and developing a plan to achieve long-term stability. And I'll come back to where I really hope to go with this housing initiative in the future, but we were somewhat tied to the federal government requirements around how these dollars are spent. So I mentioned earlier that the shifting nature of the epidemic is really presenting us with different substances outside of heroin and opioids as we've thought about them for the last several years. But I think the flexibility that we've allowed in this grant funding will allow us to implement some long-term strategies that get at that broader definition of substance use disorder, even though the funds, as they've come down through these particular grants, have to be really focused on heroin and opioids. So where you're seeing mentions of evidence-based programming and accountability around how long people remain engaged in treatment, those are dictated by the federal government, but are certainly priorities that we share in being able to show progress towards. By funding such a large-scale housing initiative, our hope is that we're able to show that by meeting someone's basic needs in terms of housing, we're really able to turn the tide of some of the horrible overdose numbers that have been prevalent in Pennsylvania for the last several years. We'll go to the next slide. So specifics of the housing projects, they must leverage existing permanent housing resources or identify new funding resources to provide sustainability. These dollars cannot be used to supplant existing projects, but have to provide for sustainability. It includes short-term rental assistance through housing subsidies following evidence-based models such as rapid rehousing, bridge subsidies, and master leasing. And I think that's really important. Rental assistance is something that we hear a lot about. It's not just the housing itself, but how people get into that housing, which is a significant barrier. So really wanted to be flexible in terms, again, of how counties and other applicants could use the dollars. It must combine a permanent supportive housing with housing first philosophy. It includes housing education like pre- and post-tenancy education, tenant rights, identification of and connection to community resources, and includes housing supports and assistance like identifying housing barriers and needs, preparation of a housing plan, assistance with housing searches and completing housing applications, assistance with identifying and obtaining existing housing supports. Just one more time on the flexibility. We know that a lot of times, like, our hands are tied with these federal dollars. Those of you that are housing providers on the phone also have trouble sometimes putting together a patchwork of funding that allows you to really address the needs that people have, particularly as it relates to case management and other housing support. So where you can pay for the housing counselor, but that housing counselor might not have funding to take somebody to their appointment for medication-assisted treatment, that we were really trying to address some of those gaps that exist in federal funding sources. So So lastly, on the implementation, it's ongoing, the current grantee selection, but should be wrapping up soon, and we should be ready to hit the ground running in the spring of 2019. Pennsylvania has been really interested in how we can use Medicaid dollars more broadly to pay for housing services and supports. And while other states have been successful on some level in obtaining waivers from CMS that allowed, for paying for some of those services, our hope here is that over a 2-year, $30 million investment in housing as it meets the needs of people for more of a healthcare purpose, that this is our demonstration waiver to CMS that allows us to integrate those housing services and supports into our Medicaid program in the future. So that's the pipe dream, but I think it's a really meaningful investment and really sets us apart in terms of how we're prioritizing getting at the root causes of this epidemic.
Thank you, Meg, very much for all that information. In the interest of time, we are going to move on to our next presenter, CareSource. And I want to also mention to the panelists, there are some questions in the chat. If you can chat in your answer, that would be great. Otherwise, after Greg is done, we'll hopefully have time for some more questions. So Greg, take it away.
Thank you. Hello, I'm Greg Peoples. I am the Substance Use Disorder Program Lead for CareSource. So you'll hear a lot of the similar language and topics that we covered in previous presentations, but the angle I'll take is a little different. So you can go to the next slide. So CareSource is a not-for-profit Medicaid managed care organization. So we have a 30-year history. We employ nearly 4,000 employees. Our home office is in Dayton, Ohio, and we have about 2 million members. Next slide. So this slide is a visual of our service area. And so we're in Georgia, Indiana, Kentucky, Ohio, and West Virginia. And the list shows our line of business, and mostly Medicaid. We do have some Marketplace and Medicare in particular areas, but mostly it's Medicaid. And kind of through the Midwest there, which the visual is important as you go through my next couple slides. Next slide. So everyone's got their slides on this epidemic. This slide centers around opioid prescriptions. And the purple has the higher number of opioid prescriptions per 100 people. And if you remember the previous slide, the areas that we're in, Indiana, Ohio, Kentucky, West Virginia, and Georgia, we're right in the center of the areas that had high prescribing rates 6 to 7 years ago, and which has moved on into further concern in this area. So next slide. So this slide is from the Health Policy Institute of Ohio. And again, visually, this is drug overdose death rates by state in 2016. And it concludes several of the presentation areas that you're speaking prior to this. Clearly, that's no accident. I mean, I think crisis leads to innovation. And our area of our scope of practice, our area, our members are in the highest hit areas. Just for some perspective, Montgomery County, which is our home county here in Dayton, had 550 overdose deaths in 2017. That is more than several states had. So clearly this is an area of concern, this is an area of interest, and this is an area of I guess, where we put a lot of effort into what we provide as a managed care company. Next slide, please. So, two things, just generally what our opioid strategy is, and I'll get into kind of the role of managed care and all this, but clearly one area that managed care concerns with is prescriptions. We have pharmacy benefits, and so we can have a lot of impact in pharmacy sort of information. So some of our overall goals have to do with, in the acute pain and opioid prescribing area, to increase the use of alternative therapies, including non-pharmacological options. That would be a goal of ours. Next would be for those opioid naive members, which in essence are new starts on opioids, to hopefully limit the dose and duration of those scripts when they're necessary. And, a third goal might be to reduce those individuals that progress onto a substance use disorder. On the quality side, and most important for us is having an increased access to and quality of treatment that is received. Again, I'll talk about levers that we can pull and not pull. As far as goals for 2018 and things we accomplished, in 2018 we reached a 50% reduction in MED for our members' opioid scripts. So the average morphine equivalent dosing, so that affects dose, so the amount of dosage that folks get for a prescription. As far as duration, we saw a 37% reduction in prescriptions over 30 days. So keeping those scripts under 30 days, and the goal would be 10 days or less. And I think some other states had addressing that in different manners. On the treatment side, one goal we had was to increase the prescribing of medication-assisted treatment. Now, this statistic is specific to buprenorphine. We saw in 2018 in particular a 31% increase in buprenorphine prescriptions, and overall over the last 3 years, we've seen a 109% increase in MAT prescribing. Next slide, please. Well, as we'll wait for the next slide, I can at least tell you about, generally about managed care. So this is a visual of kind of our traditional levers that we can pull, the areas of influence that we have, and some examples of what that might be. So since we are a payer, we pay for care. So on the benefit side, so we pay for benefits, we design benefits. A lot of those have to do with pharmacy. So a lot of our options that we can employ center around pharmacy things. So making sure that the full gamut of medication-assisted treatment options are on our formulary. We were one of the first plans in the United States to cover naloxone. Adding, if we're talking about wanting alternative benefits, alternative therapies to acute pain, we better be able to offer those, things like acupuncture and the availability of telehealth. Again, things that make services to our members easier. On the individual intervention side, this is kind of care coordination. Traditionally, we don't do a lot of face-to-face care, although we do some. We have about 700 care managers within the agency. Some of those are specialized to deal with substance use disorder. We have a Journey to Health program that works with folks that are identified moms with substance use disorder that need specialized care. Lock-in programs, if folks are doctor shopping, locking into one pharmacy. My Strength is a self-help program that folks can get on and seek guidance and resources on their own. And then having a 24-hour line that folks can call and help get into treatment. On the provider network, we do a lot of relationship building. This is trying to increase coordination between behavioral health, substance use, and primary care. Our goal would be to be on the same page with education about prescribing guidelines to allow primary care to know that they can screen and bill for some of that stuff. Kind of an education or just general knowledge of substance use disorder and substance use treatment, trying to get primary care doctors interested in providing MAT and understanding what a waiver means and how to get that. On the quality side, if there's one thing managed care has is a lot of data. So we want to get the data into the hands of the people that have impact to the care of the folks we work with. So we tried to, and I'll explain some of this a little later, but part of equality is getting folks the information they need to know how they're doing on standards. And, the newest phase is moving into value-based reimbursement versus fee-for-service in the traditional manner. Next slide, please. What I wanted to spend the most of my time on is just a little more innovative interventions. The first is centered around social determinants. CareSource has a commitment to addressing those factors that impact our members' health, things like housing, education, employment, social supports, just focusing on the disadvantaged, vulnerable, and some of the at-risk populations. Some of those examples might be, excuse me, the homeless and housing. I know a lot of folks have talked about that, and I'm going to get into a little more. But again, the angle of we don't provide housing, and we don't traditionally pay for housing, but how we impact that. Folks in poverty and folks that are unemployed. So we work a lot with our own population health department, trying to use data to identify these individuals. Folks that are in transition from hospital, from incarceration, from treatment. Those transition times we know are vulnerable times for our members. So how do we identify and then get support programs in place to work with those individuals? So a lot of folks have talked about housing, so I don't want to go into all the details of how generally housing works in every state. I think for us, the important thing for us is we believe that housing is vital. We believe it's the cornerstone of recovery. And probably 17 of my years were served in housing and homelessness. So I'm excited when I come to CareSource. I've been there just about a year, and know that we have a housing director. That person's job is to work on policy within the agency, to work on advocacy at the state and federal level, and to do some project development. Some of that project development is somewhat around brick and mortar projects like new builds, because you can never have enough housing for sure. But a lot of that is centered around service and coordination programs. So some examples of that might be in the Northern Ohio area in Cleveland, we have a project that's working with folks coming out of skilled nursing facilities to help transition them into either it's their own apartment or housing, and to make sure we wrap some service around them through care coordination and through coordination through treatment providers in the community to make sure those vulnerable times are covered. In our hometown of Dayton, we have a particular program that's working with folks in HUD housing, targeting some of those folks that are at risk or what we call imminently homeless, trying to offer other options. And again, so, hey, folks are housed, but we want to keep them in housing because we know how vital that is to other support services. For folks coming out of prison, we have a program that actually pays for housing. We cover 3 levels of housing assistance. We cover recovery housing, rapid rehousing, and permanent supported housing. So that program, which I'll talk about a little more later, to date has housed 700 folks. Life services is our mechanism for addressing some of the social determinants of health. These are services that we provide that aren't typically covered under managed care in general or under Medicaid. We employ life coaches, and these life coaches are assigned to individuals that are at risk, and they work on things like professional development, education, community supports, even things like food and housing, helping with simple things like budget and personal finance. And lastly, and most importantly, excuse me, working on employment with our program through Job Connect. It's all these social determinants are trying to help level the playing field to help even out some of those health inequalities so we can increase the time that the individuals spend in healthy activities and seeking care that they need. Under community collaborations, traditionally, CareSource has been pretty involved in the community. We were started by a social worker 30 years ago, and her community involvement expectation is pretty high. I think since the opioid epidemic, it has definitely boomed, especially because our hometown of Dayton was hit so hard. I think Montgomery County in 2017 was in the top 5 in the country. So the importance of us being involved in the community, to keep your pulse on the problem, to stay actively involved, better understand our communities and the barriers, the gaps, and to have a quick response if an adaptation is needed. One thing that I've seen in all the communities that I've worked in is that this epidemic has really forced people across different realms of the community to work together. You have treatment centers, you have managed care, you have hospitals, you have police, you have fire that get together on a regular basis and get and discuss how to work through this. So I know throughout Ohio, Northern Kentucky, and Indiana, there's a lot of task forces. So what we try to do is get involved in as many task forces as we can. I personally sit on 5 different ones, and I chair one of them. You know, they range anywhere from working with first responders to just having the more political entities involved. But again, the key is for us to be a player. So if there's an adaptation we need to make as a managed care organization, we can do that. I did want to spend a few minutes on just talking about our work with first responders. Traditionally, this is not an area that we've worked much with as well. You know, there's not a lot of billing that happens out of police force. Now, we do pay for ambulance runs on the mobile transport stuff, but traditionally, this is not an area that we work particularly a lot in. But they're important because they're on the front lines of the epidemic. It's imperative to have good relationships to be able to be a support and resources. So in Ohio, in particular, they utilize a couple things. They utilize quick response teams, safe passages, pre-arrest diversion programs. And for folks that aren't familiar, quick response is, as some folks said, after an overdose, they put peers in the hospitals or catch them up in the hospitals. Well, quick response teams actually can do the hospital, but mostly they follow up with an individual at their home within that week. So we do a lot of programs supporting the police and fire with that, particularly in Montgomery County and Hamilton County. We've given the police and fire resources they can put in their computers in their cruisers, and if they need to know how to connect to a service, get transportation for a member, sign up for Medicaid, whatever it might be, that they can have that access. And for folks that don't get training through their current mechanism, if they don't have CIT training, we do offer mental health first aid for free for first responders. The last thing I want to mention is community paramedicine. This is kind of it's been around since about the early 2000s. You know, the whole goal was to improve access to care. The idea is that paramedics and EMTs, you expand their role to provide health care to the underserved populations, kind of treatment without transport. This is not emergency calls. This is calls in between those emergency runs, and they usually center around chronic disease management. So we do a lot of work with community paramedicine groups around the states and just discuss. One of the positives of that is they usually have a pulse on the issue of the day and a hot spotting areas that need work. And part of what we try to do is what can we as a payer cover in that? You know, community paramedicine in many states is a Medicaid covered service, and you can pay a paramedic to do primary care within someone's home. Community criminal justice. I know I'm running a little low on time, but I think criminal justice we've done some really good work in, so I wanted to spend a minute talking about this one. So nationally, we know that about 65% of incarcerated adults have a history of substance use. And 1 in 13 of adults in Ohio that are CareSource Medicaid members are booked into jail every year. So it's very important for us to have a focus on this, and it's an area that has not traditionally had a good coordination of care. So we do have a criminal justice director who works with our markets to focus on this population. A couple of real quick things that we do. Currently on the reentry side, we have 3 organized prison reentry programs with the Department of Corrections in 3 states, Ohio, Kentucky, Indiana. The whole goal is to identify members prior to leaving, hopefully that some of medical information will be exchanged, and that we assign care managers or transition teams to connect to those individuals. The whole goal is to improve their access to care and to recidivism. Our community transition program is particular to Ohio. It's a grant-funded program that identifies individuals with substance use disorder. We contract with providers to go in and do what's called in-reach, so to make sure they connect prior to getting out. And we do offer some benefits that are non-traditional covered in Medicaid, including transportation, housing. As I mentioned before, that's the program we house 700 people through, and pay for life skills and employment. The whole goal is to wrap around these individuals for 1 year post-release to make sure they ensure they engage in treatment services. Some of the outcomes of that program are very good. We have seen 75% of our members that received an in-reach into prison connected to service. And compare that to only 27% that did not get an in-reach connect to service. Only 7% of those that are in housing through that program have recidivated, which is well below the national average. And of those housed for at least 3 months, 53% of those have been employed. So again, that's a population that is starving for service, and the more we can wrap around those, the better. I kind of pass on the last one. Data is important. I've talked about that. And we're going to start a opioid dashboard that will have on-demand information for our providers and specifically our physicians that prescribe opioids, that they can access and see statistically where they're at and how they match up to their colleagues in the national standards. And most people talked about peer services, and it's just something we emphasize throughout our communities, and just kind of how can we work with our providers to see how vital it is and to make sure we cover it as a benefit, which we do, and we coach people through that. Overall, it's definitely a busy time. This is a tough issue, but that often breeds innovation, and I'm excited about a lot of things on the horizon, including a lot of technology that's coming through and a lot of data that's coming out of this. And anyway, I appreciate your time, and thank you very much.
Thank you, Greg. What a lot of great information from all of you. I think we have a couple questions that were in the chat, so Brett is going to read those out and see who might want to answer them. So, Brett?
Yeah, thank you, Sue. So we had a question from Nikki Gable that I think that this is probably the most relevant to Mark's group, but Greg may be able to respond as well, since you did talk about covering some of this type of stuff. But Nikki said, I'm curious how the peer coaches are paid. Our insurance providers in our state do not cover fees because they cannot regulate them. We're definitely using peers in more places, but this is a barrier for us. So I was wondering, Mark's group, if any of you had any responses to that?
Yes, this is Rosie in Missouri, and we do pay for peer support services in all of our contracted substance use and mental health treatment agencies. We do require that they be certified peer specialists, so we have a state system of a training, a specific training, testing, an application process that the peers have to go through, so we do require that for the reimbursement. Also, peers with that certification are working in our recovery community centers and some of our other locations. There are other ways we pay them through a monthly invoicing process. So we do pay for peers, but they must be certified peers and have gone through that process.
Yeah, the only thing I would add is that we do offer billing guides for people that want to provide peer services to help to explain these are what you can bill, this is how it's overseen. So just giving some guidance on that.
Perfect. Thank you, guys. And I know that Ryan already responded to that in the chat. So, Nikki, I hope that was able to answer your question. And then we had another question that we'll use the last bit of our time for from Milagros Rosario Diaz, who asked, I would like to know if there are services for undocumented individuals and other people who do not speak English, and what kinds of services your states offer for them for opioid addictions. And that can go to anybody.
I think Meg mentioned
I did. Sorry, I was trying to unmute myself. We do that. I did talk a little bit about our workforce initiatives, which were really aimed at increasing cultural competency, and that's one of the strategies is embedding clinical staff that are trained in the language of various specialty populations to increase the likelihood that they'll engage and be successful in that treatment. And we did that very intentionally with dollars from our first round of STR grant funding.
Ryan, what's happening in Rhode Island? Anything around this?
Yeah, sure. So we have used it's escaping me which exactly, but I believe it's substance use block grant dollars can be used for treatment of undocumented people. So can SOR dollars, maybe, if I might be I might have wrong. I can't remember, but I know that we have actually set aside through some federal funds. We've set aside some that are eligible for treatment of the undocumented population. We have also set aside a small portion of general revenue to cover treatment of undocumented folks through our Behavioral Health Crisis Center. I think more broadly on care for people who don't speak English. I think there is no question that it's something we've grappled with a bit here, but that we have worked to make we've worked to make treatment resources, particularly medication-assisted treatment resources, available and culturally competent in specific communities where there are a high number of non-English speakers. So it's really, nothing too fancy in our policy approach there, just focusing to make sure that there's coverage for these services and that the organizations that are designated to provide these services to particular communities are competent, that they have language competency across the board.
Thank you. Missouri, do you want to respond to that? Question? Maybe you're on mute?
Sorry. Yeah, we were on mute. I don't think we have anything to add.
Okay. Thank you. Let's see, we have any other questions? We have 2 minutes. Anything else? Somebody mentioned in the chat that there are some transition clinic programs, a national network, so if folks wanted information about that, it's in the chat. This was a lot of fantastic information from 3 states. I want to thank Ryan, Mark, Nora, Rosie, Meg, and Greg for all their information. You got to listen to 3 states doing really creative, innovative, promising practices, and as well as a managed care organization. So thank you all very much. Again, the slides will go out. There's a lot of information on there as well as contact information. Our next webinar will be sometime in mid-May, and that webinar will focus on programmatic responses to the opioid crisis, including an organization that's doing mobile MAT to unsheltered populations. So we hope you will join us for that. We'll send out information. And thank you all for joining today. Thanks to our presenters and to the audience. So thanks and have a great weekend.